Hello, everybody. You are going to visit or to listen to a discussion of the clinicians group, of the task force of the clinicians. My name is Renee Beer. I'm the chair of the clinicians group, and I have the pleasure of introducing first myself and then all the others. I'm a Dutch EMDR child and adolescent trainer since 2003, and I'm a member of this global alliance since the beginning. And the theme of this conference, Building Bridges, is a very appealing theme for me because I'm also a trainer in trauma-focused CBT, and there a lot of bridges can be built between EMDR, I think, and CBT. So I'm very in favor of this theme. So far, this is the introduction of myself. And then I want Anne to introduce yourself.
Thank you, Renee. I'm Anne Beckley Forrest. I'm from Buffalo, New York, and I first learned EMDR back about 10 years ago, and I was a play therapy trainer and supervisor first, but since adding EMDR to my work, I really have found it to be really helpful, inspiring, and important. And so my association with this group and with doing EMDR trainings and especially bringing EMDR to my own community of play therapy colleagues has been a really exciting journey. I'm really happy to be part of this work of the Global Alliance during COVID.
Thank you, Anne. Susan, may I invite you to introduce yourself?
Thank you, Renee. It is, as Anne was saying, an absolute delight to be a part of this group of dynamic and wise people who are hoping to change the world, as Anna always says, one kid at a time. I'm Susan Darker-Smith. I'm from the United Kingdom. I'm a Europe accredited child and adolescent EMDR trainer, and I'm also actually a CBT therapist. So lovely to be here. Thank you, Renee.
Thank you. Amy, could you be the next one?
Yes, thank you, Renee. I am Amy Terrell, and I am from Des Moines, Iowa. I was trained in EMDR when I was still a graduate student. And so it's been wonderful because I would say it's my primary therapeutic lens. And then I've been able to sprinkle in other approaches. I'm also an EMDR basic trainer for EMDR consulting and do advanced trainings. I have the great privilege of presenting some of Ana Gomez's material. So it's great to be here. The Global Alliance, we have a wonderful mission, and I'm so happy to be part of it.
Thank you, Amy. Now, then you have already mentioned Anna. So Anna, can you be the next one to introduce yourself?
Yeah, thanks, Renee. My name is Ana Gomez. I was born in Colombia, South America. I've been in the United States for about 26 years and 22 doing EMDR therapy. It really changed my life, not only professionally, but personally. And I had the great honor to work directly with Francine Shapiro, be trained by her as a trainer, and collaborate in multiple tasks with her, which was very enlightening for me. I am very proud and very honored to be part of the Global Alliance. This is a group that began in 2015. I am honored to be one of the many founding members, and we have worked very diligently and with so much passion and love to create resources for children, for adolescents, and for families. So I'm very happy to be here.
Thank you. Okay, now you have seen and heard all of us of this group. So we are one of the 4 task forces of the Global Alliance. We have a task force children, adolescents, parents, and clinicians. And all of these task forces have already delivered a lot of resources which you can find on the website of the Global Alliance. And also our task force has already delivered in the past period several resources which you can find there. Our main contribution, however, so far is this conference. The idea for this conference came from this group And the organization of this conference was not only done by the 5 of us, we are helped by members of all the task forces to make this event happen. And what we hope for in our task force is that this event will be the first one of many to come. And hopefully next year in December, we will have the second one. And hopefully then it will be even a bigger one with more contributions of many parts of the world. So now we go back to this one. What are we going to do in this 45 minutes? We are going to share with you a discussion. And the discussion, the theme of the discussion is, what do EMDR clinicians need to succeed? We chose 5 themes, and each one of us will introduce one of these themes, and then we will exchange reactions, ideas on what was introduced. Anne will be the first one. She will introduce integration versus differentiation. Then I will be the second one, and I will speak on training. Susan will be the third one on mentorship. Amy, the fourth one on self-care. And Anna will introduce the theme of research and clinical practice. So now I give the floor to Anne.
Thank you very much.
Sorry, I forgot one thing to say. We made the agreement that there will be moderators, and not the one who is introducing, but the next one in line will be moderating. So I will now moderate the discussion after Anne has introduced her theme.
Thank you, Renee. So this is actually pretty exciting for me to have this conversation with all of you, because this is where my energy is really gone, as I've gone from a clinician trying to experiment with how to make EMDR a core part of my practice with children, and kind of moved along towards trying to help other people to do that through consultation and training. I've come to see that it's kind of important for us to help people to frame the question of, how am I going to take this training in EMDR, the protocol, and EMDR as a comprehensive approach to psychotherapy, and then integrate it with all of my current clinical identities. And that was pretty important to me, because when I first learned EMDR, I already had a pretty strong clinical identity as a play therapist. And I know that I was being helpful to children, but in particular when it came to trauma, there were things that were being missed. And that's where EMDR started to fill in the gaps for me. So the question is, how can we help EMDR clinicians to do the same, to take the training that they get in EMDR and make it a part of their clinical identity? And then, I have a few questions in mind to talk about some of the pitfalls in doing that with this group. So here's where some of my initial thoughts, and I think, then I'll take the slide down and we can have a little bit more of a free-flowing conversation, but just to get some of those ideas going. It's not just about what we do in the room, but it's also the conceptualization of cases that on the theoretical level that matters if you're trying to integrate more than one approach. If you have, an identity as a play therapist or as a CBT therapist, and then you're trying to weave EMDR and the standard protocol and other protocols into what you're already doing, we have to also adjust on a theoretical level, and there isn't a lot of models for how to do that. And so I'm interested in hearing how you all have already been managing that, and also where the struggles are with doing that. And I know for me, one of the struggles is looking for mentors, and especially looking at the research, because which I know we're going to talk about later, but it's relevant here in that there isn't a lot of research on integrated protocols, and that makes it hard for us to navigate all of that. And then, share some thoughts about what some of the advantages are and some of our success stories in that, and how we can help newer clinicians who may be recently trained in EMDR to integrate AIP thinking into what they're already doing. And then the difficulties to chat about those as well, in terms of what do we sacrifice in terms of model and protocol fidelity when we do that, and how to be careful with all of that. And then, the last question that I sort of came up with when I was thinking about all of this is, how, when we make these decisions, how can we be guided by the needs of the client or the patient, in particular the needs of younger children, since that's our topic. And, versus we can get very locked into therapist needs, and also kind of silos of training and credentialing and things like that, and miss sight of effectiveness. And so that's the other kind of question to kind of ask ourselves, is how we can do that. So those are some of the questions I have to get our conversation going. And I guess, maybe we can kind of start off by sharing a little bit about our own experiences of trying to do this. And I'm really interested in hearing from all of you about how you're trying to integrate EMDR as a psychotherapy approach comprehensively with things that you already do. So I'm going to go ahead and take my slide down here. I have it handy in case we need to ask ourselves the question again, but I want to be able to see everybody. So.
Okay. So who wants to react on, you posed a lot of questions. Susan, do you want to start?
Thank you for that, Anna. And I think it is incredibly important how our clinicians integrate what is familiar to them to what is perhaps less familiar. Because if we don't talk about integration, then actually accessing a new training feels clunkier and more difficult, which may then impact on retention of clinicians going forward and for the future. One of the things that I've certainly been doing much more recently is actually integrating EMDR with DDP, because I found that there's an awful lot of DDP that we can weave in terms of interweaves and attachment-based interweaves especially, and I found that immeasurably beneficial.
Sorry, Susan, I interrupt you. Can you explain what is DDP? Maybe not all our viewers will know what it is. I don't know what it is.
DDP is a way of working. It comes from Dan Hughes' work, and it's a way of helping parents to attach to children, to communicate, and to start to build connection rather than disconnection. But it is a particular therapeutic skill. And of course, what's really lovely about it is very often when we're working with children who come with broken attachment, which I know Anna's spent a great deal of her career also working towards supporting families, as has Amy and Anne and yourself, to help rebuild those connections.
So I have a question already. Can I ask?
Yeah, please.
Okay, so right, to go from the generality into the specifics, right? Which is, certainly attachment theory, very compatible with AIP theory. So at the theoretical level, where I think a lot of like people I consult with struggle is, so I've learned these things I'm supposed to be doing in the room. Play like I think what I know of DDP, it's a lot like TheraPlay or other kinds of, it's a game-based learning, it's playful interactions, experiential. And I think that one of the questions is how then, and how legitimate is it to then incorporate EMDR preparation phase installation type practices with that, or, how people can, do we want them to turn off DDP self and turn on EMDR self, or can they kind of be both practitioners at the same time? So that's one of my questions about that, not just for you, but for everybody, I think, to think about that. So
I would love to comment on this question, Anne. I feel like this is one of the big challenges, especially early on when people are being trained in EMDR and they feel like, oh my goodness, there's these phases and there's certain things I'm supposed to say and not say and stay out of the way. And how do I do all that? And I think that for many people, when they don't understand how they can actually bring their full therapist self to the work, then they start feeling like maybe it's going to be too technical. And so I think it is really important that as the EMDR community and people teaching EMDR and the advanced trainings, that we talk about how, part of being an EMDR therapist is remembering that we don't throw out all of our good therapeutic skill for a protocol, that we bring it to the work and that we integrate it as a full psychotherapy instead of viewing it as this protocol that just has 8 phases. And that we can, all throughout EMDR, we can bring those other modalities. So for example, understanding that in phase 2, that is a wonderful time to really integrate, those other approaches that marry well with EMDR, where we're looking at stability and, therapeutic practices that we know historically have been wonderful at helping with stabilization and grounding. And I think the other thing that's really key is that so many times, I think it's misunderstood that one of the key components in, phase 4 is that we are supporting the client and that we're bringing, that resonance and that connection during phase 4. And so that is where we're bringing together, other skills and other abilities that we have been working on maybe for years developing, and we don't have to throw it out. We get to have it right there and help clients through the work. So I think that it's a really important conversation.
Okay, thank you. Anna, you wanted to react, and then I think we have to close already because we are out of time So please, Anna, will you react? You're muted. Could you unmute yourself?
Yes. Okay. So I have several thoughts about this. So the first one is, when people are trained in EMDR basic training, they get this idea of EMDR therapy being very technical. And, they can become technicians. And I think that EMDR therapy is way beyond that. And certainly we need to do and know the procedural steps really well, but it's beyond just the technicalities of EMDR. And to do that, I think the clinician needs intention, to be intentional in terms of how it's utilizing the different approaches that are available or that they're training. So I have an analogy because I live in the world of analogies and metaphors. And so what I started to create for myself to first understand how to integrate what I had at that point before I was trained in EMDR therapy, then I came up with the analogy of the house. So all of us as therapists live in a house. See, this is our therapeutic house. But and sometimes we live in multiple houses. We have CBT, we have play therapy, we have TheraPlay. And so the clinician, like you said, Anne, they come in, they get trained, and then what do I do with what I already have? So I think it's important that we help them and support them in being able to integrate all of them. And so if I'm going to live in one house or if I'm going to live in multiple houses, and if I live in multiple houses, how is the decision making here? When the child comes to me, how do I make the decision to go with this house, which is play therapy, or this house that's EMDR, or this house that is CBT? Now, I live in one house. That house has 8 rooms, but also has a basement with not only the AIP model, but I'm influenced also by attachment theory, regulation theory, polyvagal theory, structural dissociation theory, and many others that I can also integrate. And I think it's important that we give people the message that not because you got trained EMDR, then you're losing everything else that you have. But instead, you can incorporate all the knowledge that you already have into that house. So you can have your house and you can bring fancy furniture from other approaches that enrich EMDR, preserving the essence of EMDR therapy. But at the same time, we have to make EMDR therapy developmentally sound for children. And for that, then we incorporate other approaches that are appropriate for kids, like play, expressive arts, right? Even polyvagal-based strategies for children with developmental trauma that can soothe the autonomic system. And so I think that the idea is to help them, to help the clinician see all the richness that they are bringing, and to be able to either create a house or intentionally know how to go from one to another, that moment to moment decision making, to know what house I'm going to go to. CBT, and the thing is, before I end, the thing is to know, why do I choose what I choose for this child? Why was CBT chosen versus EMDR? And why was only play therapy versus play therapy combined with EMDR? And I think that the most important word that I'm going to bring up here is intention. How we can be intentional and how we put it together, and how we go through, navigate through the moment to moment decision making that takes place during the therapeutic process.
Mhm.
Yeah, and I think the challenge that you said so well, I love the house analogy. I adore that. But also, like,
Yeah.
you have to have a level of skill and familiarity and depth in the different rooms of the house in order to be able to make that moment-to-moment decision with intention. And that's where I think when we have beginning clinicians, they feel very pressured by information about research about model fidelity, things they hear from their basic trainers about that, and then have to kind of evolve. So anyway, so sorry, I just wanted to add that one thought.
No. So we have a few more minutes.
Yeah,
I
we
think.
might have a minute or two left. Let's see if we missed any of the questions. Actually, we did a pretty good pretty good job of covering all of the things that I thought were important about.
Can I add then something?
Yeah.
Also to the discussion. I come from a different. Susan is also a cognitive behavior therapist, and like I am. I have I think a bit of a different angle from where I fly in. I agree with everybody so far that you are saying it's very good to integrate with what you know already. But I think it's also very important that we follow the guidelines, that we know, take notice of what research says. And when it goes about PTSD or traumatized children, in fact, there are two evidence-based treatments, and that's cognitive behavior therapy, trauma-focused cognitive behavior therapy, or EMDR. So I think that should be a very important guideline, and for us also in our thinking. And I think I agree with what was said before, that you have to make, when you work with children, you have to adapt EMDR so that it's working for children, and you can integrate a lot of ideas that come from play therapy as a means, but you can make a differentiation between means and methods. The play therapy as a method is not a directive method, but you follow the child and what he expresses with his play, and then you interpret what the child plays, but you are not directive, you are not directing the child. And I think when you work with traumatized children, you have to be directive. But with directive, I mean that you guide the child. So what I see as a danger, I see integration, and it can also be a danger. It can be, the danger of integration can be that you come to a kind of eclecticism and a mixture of models, and then you have, in fact, you end with not working according to a model. So that's my, it's more like I want to warn for that. I think we have, okay, that's just Susan.
I'm reminded, just following on from what you've said, Derek Farrell always said that we need to be vigilant to model drift, where we deviate from the 8-phase protocol, but also the reasons why. And I think when we're working with traumatized children, especially, we have two options. We either stick them in the box that says EMDR on the side, or we put the cloak of EMDR around their shoulders and let the folds fall where they may. And I think as long as we know when we drift from the model and the reasons why,
Yeah.
and the child is at the heart of that decision rather than our own aversion to seeing a child distressed, for example, because I hear totally what you're saying, Renee, and I've seen it in my own supervisees. Sometimes they don't want to do trauma-based, trauma-focused CBT or EMDR because they don't want to see the child cry. But sometimes in order to process through, it might mean the child getting in touch with difficult emotions. So as long as that decision and the model drift is in the interest of the child's healing, then I would say that's a good opportunity to weave into that fabric of therapy, whatever intervention the child needs, and let the folds of the cloak of EMDR fall where they may.
I love that analogy, Susan. And Renee, I appreciate the caution because I do think, this is, there's a model to EMDR therapy, and we want to make sure that we're sticking with that. If we're looking at the best way to help a child is with EMDR therapy, then we want to make sure that's the therapy we're doing, right? Also, though, I see where there is room to bring these other approaches, especially when, as Anna was saying, it's the child in front of us. It's the moment-to-moment decision-making of, how can I help this child begin to get closer to having some realization so that they can move into processing and have integration of the memories. And so I think sometimes we do need supportive therapies to help children. I mean, really all people, but definitely with children, just to keep it playful and to keep their attention. But I think there's a big difference between, weaving in play therapy strategies and maybe, other therapeutic approaches into the 8 phases versus just doing, random bilateral or tapping and calling that EMDR. That's very different. And I think that's an important distinction too.
Okay. Anna, you wanted to react also.
Barbara, I don't know if we have the time, but no, I do appreciate, Renee, what you're bringing up, as Amy said. I think that it is important that we preserve the heart and the essence of EMDR therapy. And I think EMDR therapy gives us a roadmap and allows to see where we are in the therapeutic process. So quite often a child may come in, I know that I'm in preparation phase. I know what procedural steps I have, protocols available. I know the goals of preparation phase. However, there is still flexibility for me to see what the child is bringing and dancing with that, right? In addition to that, see, EMDR for children are not the same as adults. Quite often children don't tell the story in the form of a verbal cognitive narrative, but children actually tell their stories in the form of reenactments that occur in their relationships, but also in the play themes that they create. That's their native language. So if that's their native language, right? And I can speak about, Yak Panza biological motivational systems, and one of which is play, and significant research that shows that the detrimental effects of being deprived from play, and a lot of our traumatized children are actually deprived from play. So Yak Panza, a great neuroscientist, advocated for actually play sanctuaries and having play as a part of the healing process of the child. So I think there is a way. I think I always hear the voice of Dan Siegel that says rigidity or chaos, somewhere in the middle. So we don't want clinicians to use EMDR in a way that is chaotic, where they don't know where they are. They don't understand procedural steps. They don't understand the AIP model. And like Amy said, they just do bilateral stimulation and call it EMDR. That's not EMDR. And EMDR is not just using procedural steps, but it's case conceptualization, like Anne said, how we conceptualize the case. And we're using the AIP model. Within that framework, then we incorporate other approaches in a way that preserves and honors the heart and the essence of EMDR therapy.
Okay. Well, I thought this was so exciting. Thank you.
Yes, very.
Yeah.
We could continue 45 minutes just on this. There's so much to say on this. Thank you, Anne, for inspiring us for this. And I think we have to move to the next one. And the next one is me. So I'll share this sheet. Okay, I'm going to talk about training. I want to focus on three themes, or three parts of this theme: trainers, trainings, and the embedding of the trainings in a whole. So first about training, trainers. As I said, I'm a child and adolescent trainer since 2003, and I'm a chair of the EMDR Europe Child and Adolescent Trainers. And I think that it's 21 years ago now that the Child and Adolescent section of EMDR Europe was founded. And during those 21 years, past years, we developed in Europe quite an elaborate track for trainers, how they are trained to become a trainer. And part of this path is also a child trainers training. And I'm now since 3 years, I'm a chair, and we worked hard in developing this. And last summer, Carlijn de Roos and I together gave the first child trainers training. And I think because of this path we have and the criteria we have, we train in Europe the trainers quite homogeneous, how do you say it? With the same kind of level. We can understand each other. There's more homogeneity, I think, between the trainers in Europe. And I think that's very important. I mean, the trainers are very influential for the quality of the trainings they offer. So that's one thing. And we have, as trainers, we have meetings once or twice a year where we exchange knowledge and expertise. Then the trainings, also for the trainings, for the content of what is trained, we have a more or less common manual. At least for the level 1, there's a common manual developed. In the level 2, there are quite some differences in the different countries what is taught, because it's very dependent on what is trained in the generic trainings. But also for that, it's rather circumscribed what should be in the trainings. And then the embedding. What's very important that so far in Europe is quite different when trainers are trained in the child and adolescent part. In some countries, they only do the child training when they are practitioner, when they have done the whole generic path. And in some countries, it is after the level 1 training. What we are striving at, what our ambition is, or our intention is, that everywhere trainers are doing the child and adolescent training very soon after they started. So we have in Holland the most integrated form. In the Netherlands, it's so that trainers do 2 days of the generic level 1 training, and then 1 week later starts the child and adolescent training. So the child people as a group are trained from the beginning, from day 1, as a separate group. And they do the whole track, they get everything. So the level 1, adolescent or adult and child and adolescent in one. So 5.5 days is for level 1, and then another 4 days later is for level 2. And the advantage of this model is that the child people are right from the beginning learn and meet colleagues who learn EMDR to apply it to child and adolescents. And the consequence of that is that we have a very high percentage of people who are trained, who also really stay working with EMDR. They become practitioner and they stay working with it, compared to other countries where a lot of people don't continue. If it's a too long time between doing the generic training and the child training, people in the beginning, they learn EMDR, but they don't know how to apply it to children. As we said in the previous discussion, EMDR with adults is very different from children. So if you don't get the tools, people are demotivated. They think, oh, EMDR is not for me. I don't want to work like that. So that's why we, from the beginning, wanted to have the child people as soon as possible learn the stuff which is relevant for child and adolescent work. And the second thing which is very important, so this is the embedding, the integration of the material. The second thing which is very important in each country is that trainers meet, that trainers have contact. One of the reasons why we integrated the child trainers training is that when people are trained as a group, there is bonding between the people who are trained, so they can support each other. And we think it's very important that there can be bonding between child trainers, but also in each country between the child trainers and the adult trainers, because the child trainings have to be very go good together with the adult training. So contact is essential. So we want to also Caroline de Roos is stimulating that through the Child and Adolescent Committee, that at least once or twice a year there's contact between adult trainers and child trainers within any country. So that way we hope to integrate the child and adolescent trainings and the adult trainings more and more. So that's how we do it here in Europe. And I hope this is helpful or gives ideas, or maybe you don't. I'm curious what you think about this.
Yeah, and I know when we asked Renee to tell us, some of us from the US wanted specifically to know more about what's going on in Europe and vice versa, because I think it's a struggle to construct this. It's already a demanding process of becoming EMDR trained, and yet there's such important pieces if you're going to use it with children that sort of can't be boiled down to like 1 hour of the full training, which is sometimes how it is in the US. Depends on your trainer, of course. There's more variation, and so I think we're just really interested in maybe asking you some more questions about the content or whatever. And I know Susan is also a child trainer in Europe as well, and can maybe add to all of that. So I'm sure we have some questions for Renee and Susan about how they do, about having a dedicated track for training and how that goes and all of that. So.
And I think we'd also find it very interesting to know how it is in other countries such as America and Canada. How is it different? Because I understand that there isn't a designated track, but then you have such expertise and richness within America and Canada, for example. We have Anne and Amy and Anna. We have such expertise, such wisdom in working and adapting the standard protocols for children. So is it more a question that it's optional whether or not you need to attend a child training? Can anybody work with children in America? How does it differ from Europe?
Amy, I know you're a basic trainer too, right? Why don't you go first on that response? How it looks that you're a neck of the woods.
Yes. So the comprehensive training, also called the basic training, includes teaching how to do EMDR. Primarily, it's an adult focus. So it is my understanding that there are a few that are emerging that are more child-centered. but typically it is, so Emdr, as you know, approves the content. So they have certain requirements that have to be met for it to be a basic training. And so all the trainings that are Emdr approved obviously meet that requirement, which is for fidelity to the model. And then we have special population sections, which are part of the Emdr standards. And that includes a section with children. And, you know, it is the longest of the special population section, but definitely I always say, you know, if you work with children, if you're a play therapist, if this is your, you know, if children are your primary population, it will serve you and your clients very well to go to advanced trainings, to, you know, do additional education and reading, because I do think it's very hard as a trainer to try to translate how this is with children while at the same time teaching how it is with adults. And I know, you know, when I'm presenting, I do my best to do that through the phases and then elaborate as much as I can in the child section with the time that we have. But I could see a benefit of having different tracks for the basic training, but I also wonder, because I feel like here many people don't do just, you know, they don't work with just children. Some do for sure, but I think many EMDR therapists work with children and then some adults, or a lot of adults and some children. And so I think it's difficult, you know, to say that to think that they wouldn't have the understanding of how to do EMDR with adults. And I'm really interested in the difference, I think, of the trainings that Renee was discussing. I'm really curious about what the child and adolescent training looks like versus the standard training.
Yeah, Renee, do you want to speak to that a little bit?
Yes, no, yeah, I can. I will gladly. But it's only globally I can. I think what we do in the child training, of course, we go through the standard protocol and go through every phase and explain what's different per phase when you do it with children. We have made the standard protocol. We have a version of the standard protocol for children from 4 to 18, and we have for different age groups, we have adapted it. So per phase you can see what's different, and we explain why it's different and for what age it's different. So that's part of the training. Another part of the training is indication. So we explain when you can apply it, when can you think would be which symptoms, which disorders. We have a section on the parents. How do we involve the parents? And then what is a very important aspect, and I'm very happy to speak about this, because it's something I want the whole world to follow, because it's very good. We have a very important aspect in our trainings, both child and adolescent, and that is videos. We invite our trainees to make videos. We tell them after we have day 3 of our training, so our first day, they have had the whole standards protocol. We tell them you can apply EMDR on children of all ages. Just do it. Make recordings of it, look at yourself, and see what you are doing good and what you can do better. And then we have in our trainings 2 days or 1.5 days that the people come, they bring their video fragments, and in relative smaller groups, they get comments on it. It's not whether it's good or bad, but we look at the fragments together and we teach them how they did it. They can explain how they did what they did and what they can do better or not do better or different. And it's just another way of dealing with the material, and not that the trainers are presenting or illustrating with their videos, but we are all learning from the fragments of the trainees. And that has that's very good means in our trainings, both adults and child, because by doing that, you lower the threshold, to start with EMDR. Very many people after the training are afraid to begin. But when you already during the training have to begin because it's part of the training, it's much easier to go on after the training. So everybody has already made fragments, and we say to them, also if you fragment isn't shown during the training, no problem. You can go to your supervisor, because we say to everybody, you have to continue with consultation after the training, because just doing the training is never enough to learn these methods. So
a couple of things that you're saying, I just want to, first of all, totally agree. And actually, the basic training that I am now a basic trainer with Annie Monaco through the Child Trauma Institute under Dr. Greenwald. And we actually have encouraged videotaping.
okay, good.
So it is part of our training. And in fact, we ask people to submit a video before they finish the course. And we spend time on it. And I think it's a great learning tool. And especially with regards to children, how we do it is, we tend to attract, because we're both child therapists, we tend to attract people who want to learn basic EMDR from a child perspective, even though we still teach the same Emdr curriculum. We probably spend more time in our case examples. We tend to pull from not just our adult clients, but also from children. And I just think the problem, kind of nationwide for the US, and I can't say about Canada, but I just think that it depends on your trainer. So if you are a child therapist who accidentally signs up for basic EMDR training from a trainer that doesn't really know child work, you'll get like a 1 hour with like a video of Anna's off YouTube. And you should really do some playing, and how about a ball with cognitions on it, and that's it. You don't get a lot of integration of the material the way that you're talking about, Renee, which is all along the way, not just as an afterthought, but here learn about preparation phase and case conceptualization and, part one, go now learn about children. Now go learn the desensitization. Now learn about how it looks different in children. So I think it's much better the way you're talking about integrating it. And some people do that, and some trainers don't, I think, see the relevance of that. So such important themes. I think we might be at our time frame for that topic. So if anyone has anything final that they want to say, or Renee, if you have any last comment, or Anna, before we go on. You're muted.
I was going to say that I'm grateful to hear the different models that have arise as a result of all of us trying to do EMDR therapy and teach EMDR therapy. How do we pass it on to the next generations? I think that we started this conversation here, but I think this is a conversation that needs to happen globally, because I think we have come up with different models of teaching. And sometimes what I've seen, and I think we're getting better, like what you're saying, Renee, I think is wonderful, because the child EMDR therapist has been, to an extent, historically a bit marginalized, where they go to the training and they don't get sufficient information. And so as a result, we may be in danger of not retaining those therapists because they leave the basic training without enough information. So I think one of the wonderful things that I think we're doing here, and that the Global Alliance is working on, is on having this global conversation and learning from one another and seeing how we can not only stimulate the trainings for child EMDR clinicians, but how we can provide the trainings and the companionship that they need to continue to do EMDR therapy and to be successful in doing so. And so for that, I think I appreciate learning about different models and see which one works, and then learning from one another so we can replicate the models that do work.
Yeah. Great. Yeah. I agree. I totally agree.
Yes, and with that, let's go on to our next topic.
Okay. That will be Susan.
I think that will be me.
Yeah.
So one of the things I really want to talk about is community and mentorship. And what I'm really interested in knowing about is what retains EMDR clinicians and what helps to support them. How do we make sure that they don't learn EMDR and then give up? Because so many do. And one of the things that I've been looking at is not only what helps to maintain, retaining and supporting clinicians, but also what creates a barrier to them being supported. And one of the things is clinicians potentially feeling supported. If there is a lack of funding, a lack of access to consultation or peer support groups, or a lack of time or other commitments, this may well have a huge impact on people continuing. One of the biggest stories that I actually am told consistently is that some clinicians working in hospital settings don't always feel supported, or consultation might be purchased, but it might be purchased whereby it's only once every 2 months. Now, that's not particularly helpful if your EMDR case has just fallen apart and you have another 2 or 3 or even 6 weeks before your next supervision. So when I offer supervision, I always offer an SOS slot just in case everything goes wrong and you don't have to wait in that way. I think for a lot of our clinicians, engaging in clinical practice is a huge problem. If they're actually working in an actual hospital, for example, and they're not getting the opportunity to use EMDR, they're kind of going to lose it. If we don't use a skill, it sort of stops being available to us. There's a fantastic video which I was introduced to recently by a colleague of mine called The Backwards Bike. I don't know if you've come across it at all. It is fantastic. It's a 7-minute YouTube clip. I'm happy to play it, but again, we probably may not have time. But basically, this very clever engineer has a colleague who makes a backwards bike for him. And what it means is when he turns the handlebars to the left, the bike goes to the right. It takes 8 months to be able to ride this bike because he gets very determined. He takes it to all of these different universities, and all of these hugely clever people from Princeton and Oxford and Harvard cannot ride this bike. They think they can, but because our neurons, our neurological architecture in the brain is so grooved into the way that we do things, that actually it takes time to be able to adapt. We need to practice. What's remarkable is also when we think about working with children, it takes his son 2 weeks. And that is remarkable because his son is 5 years old. And what's also remarkable is when he goes after 8 months of finally perfecting and being able to ride the backwards bike, he goes to ride on an ordinary bike in Amsterdam, in Holland, where everybody rides bikes, and he falls off. And he can't actually remember how to ride an ordinary bike, and he has to relearn that. So what we know is when we don't have the opportunity to engage in clinical practice and to experience using a particular therapy, our ability to use it, the neural architecture in our brain to be able to perfect it, sort of isn't as available to us. We also know that there may well be a lack of confidence, which prevents people from using EMDR, which is another huge thing. One of the things I always ask people on when I'm delivering the child EMDR trainings, how confident are you right now about using EMDR with kids? Get to the end of the 2 days, how confident are you now? And for me, I'm always looking at a 2-point improvement in confidence. And if my trainees are not giving that to me, if they're not saying that they feel more confident, then I feel as if I have failed them. Because enabling people to feel confident in using EMDR with children is incredibly important. And again, going back to Anne's comments earlier, familiarity and integration to existing trainings could actually mean that it becomes a barrier to them being able to use EMDR. They tend to default, like the backwards bike, to what is most familiar. We also know that it's vital for anybody using any form of therapy to have a sense of belonging and a sense of community. But in some areas, there may well be a lack of opportunities to connect. About 10 years ago, we tried to start a special interest group in the United Kingdom for eating disorders. It probably wasn't 10 years ago, it was probably closer to 5. And actually, nobody joined. Come the pandemic, we now have it online. We have over 70 members because it's online, it's accessible. So one thing that has come out of the pandemic is that there is much more availability to belong to online groups, which in Europe, certainly this was not as familiar as it perhaps was in America and in other countries. There may also be a huge lack of funding to join communities in order to be able and have the opportunities to connect. And in terms of continued learning and development, that may also be a huge barrier. There may well be clients that that need specialist adaptations, such as neurodiverse clients or eating disordered clients or dissociative clients, dissociative kids. And again, being able to attend, for example, a specialist training is hugely important. I think it is a shame that we also sometimes have this barrier which blocks people in Europe being able to attend some of the expert and incredible trainings that are on offer in America. It's not that they can't do it, it's that they can't count the CPD points. And personally, I think that's a real genuine tragedy, because I think we need to be building bridges, not walls. And I think we need to be working together as an EMDR community and doing exactly what we preach. We need to be creating community. And in doing so, hopefully, our therapists will feel that they are also supported. So I want to, if appropriate, and Renee, I believe you'll be moderating for me. I want to just open this up. Oh,
it was me.
I do apologize.
It's okay.
And I just really want to hear, what do other people think? What are your views? What do we need to do to make sure that we encourage, we motivate, we ensure that people have opportunity to experience delivering EMDR with children? How do we get to that point? And how do we make sure that there are less barriers and more opportunities?
Susan, I so appreciate your perspective here. And I love the backward bicycle. One thing I was thinking about as you were sharing that is, Dan Siegel talks about one of the biggest barriers to learning is being able to set aside what we feel we already know. And so I wondered about, the 5-year-old being able to ride the bike backward because maybe he hasn't ridden a bike forward for so many years the way other people would have. And so, yes, I feel like what you shared is so important for us to discuss. And I would love to hear from other members. Anyone have some ideas here? Yes, Anna.
Yeah, I have. So first of all, I very much agree with Amy. That was beautifully said, Susan, because I think in the process of learning, there's also a process of unlearning. And so you touched, I think, several points, but there are two that really stood out for me, Susan. The first one is, I can summarize it in companionship. I mean, we are social beings. We need our social context. And when we are accompanied through our journey, we do better. I mean, social baseline theory has incredible research on this. We do better when we are accompanied compared to when we are alone. And so for the EMDR child therapist, I think the type of training that is receiving with enough information, but also companionship in many forms. See, companionship comes in the form of additional trainings, consultation, providing videos, getting supervision. These are all different forms of companionship, but you said it, they don't have access to some of these resources. Sometimes because the child EMDR clinicians has to pay more in some parts of the globe. So they have to pay for the basic training, and then they have to pay for extra trainings that will provide the specifics on how to use EMDR with children, right? And sometimes, not sometimes, but EMDR child clinicians in general, sometimes don't make the same amount of money. And so they don't have the financial means to pay for this. Now, one of the things that we as the Global Alliance are doing is providing resources for free at no cost. You also bring another important point, Susan, and is how we can be more global. How can we really look at the walls that we have created around the world and see if it's worth maintaining them. So for instance, if there are clinicians here that want to take trainings from Europe, can they get credits and vice versa? Can we even as a global alliance be a mediator for starting to build bridges? Like you said, Susan, I love that part. And really looking at some of the walls that we have created and if they're worth keeping. And so I really hope that the Global Alliance creates change and movement, right? That can improve the process of learning and utilizing EMDR therapy for our child EMDR clinicians.
Yes, thank you, Anna. And I saw Anne wave her hand. So I think she
we all
also
got excited. We all raised our hands. So just one thing that I want to say is about growing leadership. So what I've tried to be very intentional about in this last year or so is identifying, clinicians who are in the certification track, who are obviously already doing a good job of doing all the things we want in terms of integrating the child work, EMDR successfully. They're going to the ongoing trainings, whatever, and then really trying to invite people to consider. We have the approved consultant is the next track. And I think until we have a lot of approved consultants in our system who can then provide child-specific consultation to people who complete courses, then we don't, because right now we don't have enough people who are approved consultants who specialize in children, especially younger children. And so trying to grow the next generation of leaders, I think, is something that I just want to mention the importance of.
Mm-hmm. That is so important. Yes, Renee also has a comment.
I would like to comment on something of what Susan said and what Anna said. On the question you raised, Susan, about what kind of ways there could be to mentor and stimulate people apart from the trainings. We have in Holland, as part of the practicums we all have in our trainings. What we do in our practicums, we make groups we organize that the people are in groups in practicums who live relatively near each other, and we say to them, we do that extra on purpose so that you can make intervision groups easier afterwards. Now with the online developments, the geographical distance becomes less important, but we stimulate people in the trainings not only to take supervision afterward, but also to look for colleagues with whom they can share experience, exchange experience, intervision groups. So that's one thing. And another thing is what people need, of course. We all need success experiences. It's very important that newly trained trainees have positive experience. And of course they will. I mean, you cannot have not success if you apply EMDR. So it's just, you have to just do it and then you will have successes. So that's the second thing. Just motivate, they have to be motivated to start doing it. One remark to Anna's remark about globalizing the trainings. I think we have to take into account that, especially in Europe, that count. I don't know how that's in the other continents, but we have a rule in Europe that it is, and when there's a trainer or there are trainers in a country, they have, let's say, like a territory. It's like if it is in a country a trainer and someone of another country wants to train there has to be agreement with the association and with the trainers, because otherwise it will be very unclear who is the trainer. So I think we have to take that into account and to take, yeah, that's it. So I think it's because sometimes we get mails from American trainers who offer also online trainings to come into Europe to do online trainings, and I think this is not a development we want. I mean, of course, it's a good development when there are no trainers, when there is nothing. I mean, it's better that there's something than nothing. But if there are already trainings and you would offer from another country, continent or country also trainings, so that's the other side of the medal.
Yeah.
And I understand,
Renee. Yes.
sorry, I understand the rationale for having regulations over accessing trainings from your own country. And it makes sense that culturally, those trainings will be more in keeping with understanding the perspective of that country's way of doing things. However, haven't we evolved since the pandemic? Hasn't the pandemic changed everything? Haven't we now got an opportunity where we can learn and grow from one another? And instead of monopolies and oligopolies, don't we have the opportunity for a truly democratic world where people have the right to choose which trainings they attend? I understand the two, but what if we...
It's always good to have choices. That's for sure. That's always, but I think it can also be confusing. I mean, when I speak for myself, speaking from the Netherlands, and I think I speak also for Europe. We have regulations. We have, when you offer it as extras, when you have, for example, say now because of the pandemics and there's all kinds of online trainings, there will be a kind of extra. It could be different, but also that it could also cause confusion. But it doesn't have to be. I mean, it's not that I want to say I'm against it, but I just want to warn for this.
Yes. All right, Renee, I think this, like some of our other topics, is one that we could continue for a very long time. And we have, but what has happened here is this really important conversation around, respecting our cultural differences in different areas regarding trainings and the procedures around that and the policies, and also the question that is being asked, which is there an opportunity at times to start building bridges through fences? Or maybe sometimes that is not going to be the case. So it's a really important conversation, I think, that's happening in the mental health community and the EMDR community especially. Okay. So, Susan, do you have anything you want to say to wrap up?
I think that everybody's comments have been hugely enlightening, and I continue to believe that there is a difference between the accredited child and adolescent trainings in Europe, which is part of an accredited pathway, and additional trainings, which are specialist trainings, such as in dissociation and in more complex presentation and in neurodiversity and in eating disorders, which I know that you're going to speak on during this conference, Renee. And I do think that everybody should have the opportunity to learn from specialists in those areas, regardless of where they are.
And I want to say something very short, because I was not referring to basic trainings, but to the advanced trainings. So just a clarification.
Okay.
Thank you. Thank you, Anna. Okay. Just 1 second here.
Technology is great when it
Oh
works,
my goodness.
when it doesn't.
Oh. Well, this is more a matter of, I think, the person who is trying to do the technology.
We'll just talk amongst ourselves for a moment.
Sorry.
You just have a very artistic brain that is wonderful for adapting and modifying for children, Amy.
Oh my goodness.
Well, just in general, the whole like learning edge of having to present virtually for trainers, I think
Oh,
was a
goodness.
real growth edge during the pandemic. But it really has, the feedback, I think, has been that it's been so valuable for people who are geographically isolated. And there's certainly the US is a huge country. There's many places where there's very few EMDR clinicians, and yet we want EMDR to reach those places. So.
And certainly I've just done my very first training.
We're just killing time, Amy. Just go ahead.
Thank you. Okay. I'm just not sure what I did here, but I will get there.
Okay. Well, I've certainly just done my first training ever with a deaf attendee who prefers to be referred to as deaf rather than hearing impaired. And it was certainly amazing to be able to deliver it online with subtitles for everything and translators on a separate Zoom screen. I don't know that would have gone so well on a face-to-face training. So for people with difficulties, such as communication difficulties or disabilities, I also think online offers a huge array of possibility.
Okay, there we go.
So how much time do we have in general? Just curious.
I have no idea where we are.
Okay.
Yeah.
Can everyone see my slides?
No?
Oh, shoot.
You have to share the screen now. Yeah, are you sharing?
Let's see.
So Anne, how much time are you?
I'll put it in the chat.
Okay, great. Mhm.
We can see it now, Amy.
Oh, good. Oh, my goodness. I'm so sorry, everyone. I don't know. I definitely.
Now it's good. It's good.
And then I couldn't figure it out. So, okay, as you can see, these are my very clinical slides. What we're going to talk about here is how we can be good stewards of our life and practice, and really how we have an ethical imperative to practice good self-care as mental health professionals and EMDR therapists. And so an analogy is, I think we could think about firefighters, and firefighters have their protective gear, and we wouldn't want them to be, coming into our home to save us or do their job if they didn't have their protective gear. And for clinicians, for therapists, our good self-care is our protective gear. And it's necessary for us in order to have longevity in this field, and also to have an ethical approach to the work. Because if we're not doing our own inner work and practicing self-care, then it's going to be very difficult for us to stay present with clients. And also, we deserve to have self-care and have it enhance our life. So without self-care, we will lose our longevity in the field. And so I wanted to just point out that what I'm sharing here is not bubble baths and pedicures, but instead it is about weaving into our life components that are self-care. So an awareness of our own needs, having introspection, looking deeper if we do notice any of our own emotional activation when we are being present with clients. Also being aware if we have none. That is, the flip side of it, that we should still be able to feel our feelings. And if we are noticing that our own emotions are either interrupting our ability to be present, or that we're feeling very numb, then we want to look much closer at that. And really, I would say we have an ethical obligation to. And so in terms of what all it means, I would say it's also about caring for our core self. So not just, self-care as a therapist, but because one of our primary tools as a therapist is ourself, then we want to think about, what is it for me that has meaning? What is it for, me? Each of us has to ask, that allows me to live in that meaning? And how does that apply to my practice as a therapist? And, integrating life enhancing activities, not just on the weekend. Self-care is not just, oh, well, in a month when I have time off or this weekend, but it is really part of our daily practice as therapists, because it's what promotes our ability to be good co-regulators and also to be present enough that we can make those moment to moment decisions that are necessary in the practice. And so we want to look at our own lives and think about self-care is really weaving in approaches that allow us to live with awareness and intention. And for everyone, it is different. What fills up my cup could look completely different when someone else thinks about what is fulfilling to them. So in terms of that, the other thing that we want to think about is professional support systems, because the professional support system has been talked about already, and is part of this, because it's through that professional support that we can have better insight into what it is that we're needing for self-care. And sometimes it can help us. Sometimes it can help us to see things that we don't see. And that's why the mentoring is so important. And then I'd say one more piece of this has to do with ongoing education. And that, is another topic that we have here, which is all about seeking the trainings that we need to in order to feel that we have the tools we need to help our clients. So the ongoing training, seeking mentorship, living life with intention, and being aware too that it could be ever changing, that what works for me when I'm a new therapist might look much different after 10 years of being a therapist, what I might need to do differently for self-care. I would say that thinking that we can, walk this path with clients and not take on some of it, not be sometimes altered, is the same thing as thinking that we could walk into the fire and not feel those flames. And so the best thing we can do is have that protective gear, which is our really good self-care. And so I would love to open it up to conversations, and I would love to hear, your ideas of self-care from the panel.
So Amy, thank you so much. I'm going to be moderating this portion, and that was a beautiful presentation. And thanks for sharing and putting it together in such a clear and cohesive way, because it's the relationship with ourselves and how that also impacts the therapeutic outcome, right? What's the difference between doing EMDR therapy with a therapist that is able to mentalize, synchronize, resonate, and respond contingently to what is emerging in the therapeutic moment, right? Moment to moment. And does that have an impact? And it's a commitment to our existence. So I'm so glad that you brought this up. Of course, this is another topic that we could dedicate hours to this, but I'm going to open it to the group and see what are your thoughts about this?
Well, I just have one thought that has crystallized for me over the years that you really lit, you kind of resonated and you lit me up when you said this. When you think about vicarious trauma or secondary trauma in the helper, in my mind, it's about helplessness. So we actually are capable of holding a lot if we don't feel helpless. When we start to feel helpless is when things begin to unravel for us. And so, good training and a good tool. And I think that's certainly for me, EMDR and Francine's work really played a role in that I had already been walking with traumatized children and was feeling helpless at times in terms of helping them to heal. And EMDR as an additional tool has been so profound in the ability to really, how do you lead kids to that thing which they would rather avoid? So in order to heal. So I would just say, whenever I'm starting to feel helpless, then that's when I have to figure out, do I need more training? Do I need a consultation? Do I need a colleague? Do I need a vacation? All of those things. So.
Yes, I appreciate that insight that you notice. I appreciate that insight that you notice for yourself. An indicator that I have to do something different is that awareness of feeling helpless.
Anyone else?
Guess I'm going to moderate my own, Anna.
Okay, well, I'm good. Go for it. So Susan, go for it. But you're muted. There you go.
So one of the things I'm really reminded of is seeing a wonderful piece in the British Psychology Journal about somebody who's talking about how she has this particular essay to do and how she decides that she's going to take a bubble bath instead. And actually she makes the reflection, actually, I feel a whole pile better about it when I refer to it as being self-care rather than procrastination. But I do think there is something about self-care, and actually if we don't take care of ourselves, I love the analogy that you used, Amy, of the firefighter wearing the protective equipment. When we go in to work with some of these kids, we actually risk vicarious trauma ourselves. We risk burnout. It's exhausting sometimes hearing difficult stories and feeling difficult emotions and being right alongside, in connection and in communication with the kids that we're working with and their families, who may well also feel overwhelmed and have vicarious trauma of their own. And if we don't self-care, then I wonder if that's where burnout comes from, a lack of self-care. And I wonder if maybe that's the reason we have so many nurses and doctors with vicarious trauma and compassion fatigue. Maybe it's about teaching so many of our therapeutic community, not just our therapists, but also those who've been working at the front line during the pandemic, to maybe take a moment in self-care and maybe remember that sometimes we need some self-compassion as well. So thank you for your comments, Amy. They've been hugely enlightening.
Okay, anyone else?
Yeah, it's a bit different about the self-care. Very often people during trainings, also when they see the videos that we are using during the trainings, people sometimes ask, are you not afraid of becoming traumatized yourself when you are doing this a lot? And then we always say, when you know how to apply EMDR, it gives you a, how you say, a holding. It gives you, because you have a protocol that you can hold to, you have a structure for yourself and for the clients. It's something to hold on to. That's the word, to hold on to. And that avoids, it prevents you from being traumatized, and it prevents, of course, also the patient of becoming traumatized. So the protocol in itself is a way of giving you self-care, I think. For a part, of course, this is not the whole story, but I think it's a very important part.
Yeah, thanks, Renee. And I have to say, Amy, I appreciate it when you said self-care is not just taking a bubble bath and lighting a candle, because really it's a commitment to our authentic self. And even to find it, to find that authentic self, and on a daily basis to say yes to what gives us life, and to have the courage to say no. That's self-care too. Self-care is a commitment to knowing ourselves, to embracing our own inner world, and embarking on this journey towards self-exploration. I think that's part of self-care, you know, because especially like in my experience working with severe traumatization, we're going to be with clients that could potentially activate our own unintegrated memory networks. I mean, these are children that could become aggressive, that can call us names, that can tantrum for an hour and scream in the office. And so they really stretched our regulatory capacities. And so without the self-care, then it really bleeds into the therapeutic process and the therapeutic outcome. So I have to say, EMDR therapy has impacted my professional life, but my personal life, as I have also received EMDR therapy, and that has made such a difference. I just think that we need to de-shame therapy, you know, and de-shame the things that most of us human beings experience at some point in our lives, and to come out of the closet and say, hey, trauma, adversity exists in the lives of all of us, and then we embrace each other as a community. We create a space for us to feel safe to be humans. And I truly believe that to do this work, again, if you just know the procedural steps very well as a technician, you know, then you can become a technician. But to move it forward, you also need this inner work that has to do with taking care of ourselves, the commitment to healing our own selves. And in that process, we're human, right? And so we know what it is to be human. And with that, I feel, as I look and reflect upon my own journey, that we can accompany a lot of these children with that knowing of what is to be human at such deep level. I don't know. I better stop because then I become very existentialist.
Thank you,
We're
Anna.
speaking from the heart.
Yes. And I so agree that, you know, a major part of self-care is attending to the things that we still need to heal from. And I think that also allows us to become better therapists, because now we're not blind to certain issues that we might not see otherwise. And then I just want to wrap up by saying, you know, I appreciate all the comments from everyone, and think that they're really important insights. And Renee, I agree with you. I feel like I would not have probably stayed a therapist if I didn't know how to do EMDR, because it is so incredibly hopeful and offers, you know, an approach that we know is going to help people. And for me, that has made a huge difference, especially working with, you know, survivors of human violence and some of those really difficult things that we hear. And then I just want to wrap up by saying, remember that, you know, sometimes self-care might be a bubble bath, and other times it's setting boundaries. It's having assertiveness over your schedule. It's thinking about what's going to, you know, energize your life, learning how to be present in the moment, those sorts of things. And sometimes it takes looking at what we do need for that. And that's the first step. Thanks for the opportunity to talk about this.
That's beautiful, Amy. Thank you so much. And I absolutely agree with the responsibility that we have, and that Renee brought up in terms of knowing our road and knowing our map. So that is important. Okay, so I'm going next. Should I just jump in? So let me share my desktop. It's a very small, short slide for all of you. And so the topic that I'm going to address is, oh no, wait a minute. that I'm going to address is research and clinical practice. And I believe that this is probably an area where we can have tremendous discussion and also growth, because clinicians and researchers have made EMDR therapy grow to where we are right now. I am personally very grateful for the clinicians and grateful for the researchers that have also moved EMDR therapy to where it is right now, and to get the stamps of approval from very reputable institutions. And that was done a lot because of the efforts of our researchers. Now, clinicians have also supported this process. A lot of the clinicians that are in the trenches working with very difficult cases. But historically, and this really goes beyond EMDR therapy, but there is this split between the scientist and the practitioner, the researcher and the practitioner. And the question, I have several questions for you. Are we in the EMDR community, are we working congruently? And how do we know if there is a congruency? So on one hand, how much, for example, clinicians are influenced by research? How much are clinicians utilizing what research is providing? And the other question is the data that is provided by research fulfilling the needs of clinical practice? Can we practice only with research? Okay. And does research answer the clinician's dilemmas? So when we are in front of a client and we don't know what to do, is research the first thing that we go to? Or do we go to other places? And if we go to other places, what places are we going to? And if we're not going to research, for instance, because in that moment when I'm with a child that is challenging me, I'm going to admit it to the world and to all of you. I'm not going to numbers and I'm not going to what research is saying. I'm looking at my intuitive self, what's emerging, what I have learned from trainings and workshops, for instance. And so if this is happening across the board, then are there changes that we need to make to support the joint collaboration between researchers and practitioners, right? I hear quite often that researchers want to influence clinical practice, right? And so is it happening? Are we using that data? Okay. And how can we make sure that not only research influences clinical practice, but is clinical practice influencing research? Can we work on creating a bidirectional relationship where we influence each other, where researchers can hear what we clinicians need to understand and study? The human mind is a very complex one. So it's difficult to research the intersubjective field, for instance. So there are phenomena that takes place and that occurs in the therapeutic process that, I wonder if we have the methods right now to research it, right? The variables and the phenomena that influences clinical practice, the moment-to-moment decision-making, intention, right? Co-regulation, being a co-organizer for the child, being contingent, and how that impacts and influences the therapeutic outcome. Do we have the methodology to research such deep phenomena that ultimately influences the therapeutic outcome? And so can we sit together with researchers and practitioners and talk about what needs to be done for research in EMDR for us to be able to use the data that is emerging from research? So let me give you a few examples. For instance, I am someone that is highly influenced by attachment theory, neurosciences, regulation theory, etc. And so when I take a look at most research studies in EMDR, there is no mention of attachment history. There is no mention of the parent-child equality relationship. So for clinicians, this is important, so we can take that data and more efficiently and effectively utilize it in clinical practice. We need to also research not only or do research to prove EMDR therapy is effective, but we also need to see how EMDR is more effective and with what populations. Maybe we find a difference between working with a child that has some neurodiversity or complex trauma or developmental trauma or severe dissociation versus a child that doesn't or has a single incident trauma. And so my question to all of you is, where are we in the EMDR community? And what do you think that we need to do to be able to unite researchers and practitioners so we can support each other, influence each other, and the data that is collected is more efficiently utilized to help children heal? Because isn't that the ultimate goal that we have, both practitioners and researchers? We want to support children. We want to help the future of our world, which are children, to be able to heal. So to do that, we must find a way to work together and have a bi-directional relationship. So I'm going to stop sharing and I'm going to go to you, all of you, and see what are your thoughts about this. And I think Anne is moderating. Or
It's Susan, actually.
It's me. I want to start off by saying a huge thank you for raising this topic, Anna, because I think it's incredibly important. And for a long time now, it's felt as if researchers were on one page and clinicians were on another. It's felt as if clinical practice and clinical guidelines aren't necessarily the same guidelines that emerge from research, and that perhaps in research they have very carefully selected populations for research projects, which isn't automatically the complexity that we see in clinic. For example, there is a huge paucity of information on the use of EMDR with autism. One of the main reasons for this is thought to be because autistic individuals are automatically excluded from research. So we know that exclusion criteria means that perhaps what we see in clinic isn't necessarily the same information that's coming out of research. And I totally agree. There does need to be communication and a lifting of walls and a bi-directional relationship between research and clinician in order for each of us to learn from one another towards making the world a much, much better place for generations yet to come. So I want to thank you hugely for bringing this topic to our forum today. Can I just open up the floor and just check in with our members? Renee, I see that you have your hand up.
Yes, thank you. I join you, Susan, in your comments. I also am very happy, Anna, that you raised this point, because this is also a point I share with you, that it's hugely important. And I want to say several things about this. I think it's a difference, first of all, between the United States and Europe. I think in the United States, where, as far as I heard and I have understood, most therapists are working in private practices and not in institution. Is that correct? Or is it a wrong?
It would be a mix, I would say.
Because the thing is that when you are working in private practice, you have less access to researchers or to do research. It's more difficult than when you are working in institutions. I thought that was one of the explanations why, relatively spoken, from the United States, not so much research was coming, but maybe that's not the reason. It's very important that more research is done. And I think in the Netherlands, there's a lot of research going on. It's mainly with adults, but EMDR with adults, but also with children. A lot of projects are going on now. And Carlijn de Roos recently did her PhD. She has done some big RCTs on EMDR with children. And also during this conference, Ietje van Pelt and Petra Fokkema are going to present on a research with what is a new development in the Netherlands, intensive trauma treatment, where EMDR is combined with exposure techniques and movement. And the children get the whole day a treatment in 1 or 2 weeks, and they are going to present research on that. So there's a new development, especially in the Netherlands, but I think, and I hope also in other countries, more research is going on, and it's essential. Francine already has said it every time she came to Europe, research. I did a few years ago, I wrote in the journal of EMDR, I wrote a systematic review as a clinician. I am not a researcher, I'm a clinician, but I have been working in an academic setting where there was research. And I spoke from the perspective as a clinician about research. And also in that systematic research, I mentioned some questions which are relevant for clinicians, as you say, Anna, because it's very important that the research that is done is relevant for us as clinicians. And it has to be a back and forth communication, because the data that are found have to be integrated in clinical practice and the other way around, because there's a lot of research that is done that never goes to clinical practice, or they're researching things that are not relevant for us. I think it is not, for example, what is not necessary, in my opinion, as clinician anymore, is research to determine whether EMDR is effective, because we know now it's effective. So it's a waste of money to spend more money on that. But as you say, Susan, it's relevant to find out for which children, for example, with autism or other categories, for which children is it relevant or helpful, and in which children is it less helpful, and what can we do to make it more effective. So that's the main thing I wanted to say now.
Thank you, Renee. And just opening it up, I can see Anne. Would you like?
I just wanted to respond because I actually think you are, Renee, a great example of a clinician stepping up in that gap with research and thinking about how, it might actually take partnerships of research teams that include clinicians in their program design, so that they can study what it is we're actually doing.
Yes.
And I'm thinking about, Anna's, protocols and some of the things that we're trying to do, in terms of using play and therapeutic play techniques to support EMDR. But wouldn't it be great if we had research that was helping us make those moment-to-moment choices? Yes. By saying, okay, this kind of bilateral stimulation in children, this tactile BLS is superior to this, or let's forget about eye movement. I mean, there's all kinds of things that are happening in the clinic, in the setting, that research has not yet given us any feedback on. And I do think one problem in the US is that the difficulty institutionally of studying children is a real barrier, because in order to get review board approval to study children, it's extra steps. And when people are working on their dissertation or they're doing research, they think, it's so much easier, let me just research adults. But we have to push past that. And I think offering, as clinicians, finding a way to partner, like, with people who are able to, do the research design, and we can help with that, I think is a great idea. And I think that's a good model. Yeah.
I was going to add a little piece about the populations that we study, because the children that participate in the study, are they the same as the ones that we see in clinical practice? And I'm going to speak specifically about children that are very well defended. So we know, that a lot of the children with complex trauma, chronicity in their experiences of trauma, they of course had to develop defenses, trauma-related phobias, right? They may be even phobic of the memories and rely heavily on avoidance. Wow, those are the kids that I get, And so I always wonder, when I read the studies using EMDR therapy with 8 sessions, and then you see, wow, incredible changes. And so I looked at some of my kiddos, they do really well, but some of them, it takes much, much, much longer. And in fact, I have to use a lot of time just to work with defenses because they just don't even want to be in therapy. They don't want to access the memories. They don't want to do the work. Now, to be part of a research, you somehow have to say yes, right? So in research, my question is, are we getting the kids that are more ready, that say yes, they can go in right away, process a memory. But in clinical practice, then we see the defenses, the avoidance, the systemic issues that we're trying to deal with, And so one of the things that I wish, for example, and I would like researchers to hear us, is the population that's being studied. Can we study the populations that resembles more closely what we see in clinical practice, right? So that way the data that is provided through these research studies, it can be more efficiently and effectively used in clinical practice. Certainly, there's a lot of research, definitely, that has helped us prove that EMDR therapy is effective. But then we need really for researchers and clinicians to come together so we study the same population, because are we studying the same population? That's the question.
I'm aware that we only have a few moments left. I just want to thank you for bringing this hugely important, like every other topic, we could spend 45 minutes just on this tonight. One thing that I also think might be worth mentioning is perhaps the way to start a dialogue is perhaps to start amalgamating single case studies of the more complicated young people. And that way we can build trends, which then could inform research on what clinicians feel needs to be researched. So any final closing remarks on this topic, Anna?
Well, I would like to ask Amy, because I know, Amy, you didn't have a chance, if there's anything that you would like to share or say.
I think this is a very important consideration about, are the same, children that we see in practice, the population that's being studied, and I also wonder about other factors, because, one thing I wonder about with complex trauma is, how is that defined? When, for one child, it could be so many attachment wounds, and for another, maybe they fall in that complex trauma category, but how are those, traumas different and might be impacted in a different way? And how do we define that with research, along with the therapist, right? And their ability to be present and to offer appropriate moment-to-moment decisions. To me, that's so complex to think about.
Mm-hmm. Well, thanks, Amy, and thanks to all of you. I think we're starting so many different needed conversations. I think from this we can continue to expand, because that's how we grow, and the idea here is to grow globally and grow together, and we have to start asking the questions, right? And challenging some of what we have. And I think that the collaboration, this bi-directional relationship, will definitely support the movement of EMDR therapy. So thank you.
Okay, thank you all. I think we have had a very, for us, interesting discussion. I hope for the viewers it is also inspiring and interesting and resourceful, because that was the aim, to be resourceful for the clinicians. So thank you all for your input and your exchange, and our exchange of ideas. And we can build a whole conference only on this, what we discussed. So see you all.
Bye-bye.
Bye.